How are you, everyone? My name is Nyaguthie Githae, and my research topic is on determinants of antenatal care booking among pregnant women in selected hospitals in Embu County. Antenatal care is one of the 4 pillars for safe motherhood. The main objective of focused antenatal care include promotion of health, prevention of diseases, early detection of diseases and their management, and complications readiness and birth preparedness. That's according to Kondale et al. 2016. Birth preparedness. It's recommended that pregnant women should attend at least a minimum of 4 comprehensive antenatal clinics. First visit should be less than 16 weeks, second visit at 16 to 28 weeks, third visit at 28 to 32 weeks, and fourth visit at 32 to 40 weeks. That's according to Njoroge 2012. Despite the recommended gestation of a pregnant woman to attend antenatal care booking, a significant proportion of pregnant women in developing countries attend booking visits after the first trimester. That's according to Owendo 2015. Globally, 82% of pregnant women attend antenatal care booking visit during the second and third trimester of pregnancy. And you find that this late antenatal booking attendance leads to approximately 515,000 deaths every year as a result of complications related to pregnancy and childbirth. That's according to ERIN 2014. This was supported by another survey done in Ethiopia, which revealed complications of pregnancy as the leading cause of pregnant women death, whereby it was found that 385,000 women usually died due to complications that occurred during pregnancy and childbirth. That's according to Torera 2015. On a study conducted in Nigeria on barriers to antenatal care attendance, it was found that infrastructure to assess the health facility was also a problem. In the same report, for those who assessed the facilities, they were unable to afford the services in other health facilities. So the services were unavailable. That's according to Edemudia and Fagmabid 20. In a study conducted in Kenya, it reported that in order to initiate antenatal clinics in the second and third trimester compared to other countries which were under study, mothers feared to be reprimanded by healthcare providers. Others cited mistimed conception, experience of previous pregnancy, especially those who suffered complications, motivated the pregnant mothers to initiate antenatal clinic. Long waiting time and staff attitude were cited as barriers to attendance of antenatal clinics in the study on barriers and facilitators to antenatal delivery care in Western Kenya. The pregnant mothers who wanted the pregnancy were found to attend all the clinics as scheduled, while those who had mistimed pregnancy or unwanted pregnancy were rarely seen to attend the clinics. That's according to Achako and Yeshuhi 2016. Increase in age and the fact that the pregnant women are married increased utilization of antenatal care among these mothers in Malaysian setting. That's according to Yuan et al. 2016. Now let's proceed to materials and methods. A cross-sectional descriptive study was conducted in Embu County targeting pregnant women attending antenatal care clinics. So the study involved 110 respondents, randomly sampled from Kianjokoma, Kibugi, and Keretire health facilities. These facilities are found in Embu County. During a preliminary survey done in the 3 hospitals in Embu County, Kenya, it was evident from Ministry of Health registers that majority of the mothers reported to book for ANC visit in the 3rd trimester. Methodology. This predisposes them to late screening, diagnosis, and treatment of preventable conditions which would affect the pregnancy outcome. So the reliability and content validity were established before actual data collection during pretesting. Research assistants were trained before administering the questionnaires to the mothers. Ethical clearance was sought from National Commission of Science, Technology and Innovation in Kenya and from Embu County Department of Health and Facility Administrators. Informed consent was obtained from the respondents before participation in the study, and confidentiality of the data collected maintained. Let's proceed to results. So, according to the results, the ages of the participants ranged from 19 to 49 years of age, with a majority of them in the age bracket of 20 to 30 years. Majority of the pregnant mothers were Christians and married, that is 91% and 82.7% respectively. On employment status, most mothers were either self-employed or housewives, with the majority having secondary level of education. So the summary of the demographic characteristics of the pregnant mothers who participated in the study as shown in figure 1. So this is the representative of the demographic data that I got during my data collection. So the age of the participant was not significantly associated with booking for antenatal care clinic at a p-value that is less than 0.05. Sorry, that is greater than 0.05. So it wasn't significant. However, older pregnant women were reported to be free to initiate the antenatal clinics at any gestation, while the young mothers tend to initiate their clinic at. Religion of the participant was also less likely to influence the timing for initiating antenatal care clinics. Majority of the participants initiated their clinics in the second and third trimester regardless of their employment status. Housewives mostly initiated the clinics early compared to the employed mothers. However, this was not significantly associated with timing to initiate antenatal clinic. Out of 15 mothers who had primary education, 13 of them initiated the antenatal clinics after 6 months of gestation. Only 3 mothers had a degree level of education, and they booked their clinic late in the third trimester. So it was also revealed that 46.4% of the respondents had a secondary level of education and initiated their clinics in the second and third trimester. During multiple regression, level of education had a positive association with employment status and being previously pregnant. When these two variables were adjusted and subjected to chi-square analysis for time of initiating antenatal clinics, it was evident that the association was insignificant. That is at a p-value of greater than 0.05. Majority of the respondents were married, with 17.3% of the participants being single. There was a positive association between being married and having been pregnant previously. As the age of the participant increased, there was also a positive correlation with the marital status, many being married as they aged. Despite the positive correlation, marital status was not significantly associated with initiation of antenatal clinics. That was found at a p-value of greater than 0.05, which was not significant. What about past pregnancy experience? So information was taken, and this is what I got from the participant. Most of the participants, that is 60%, had been pregnant previously, and out of 66 mothers who had been previously pregnant, only 8 initiated their antenatal clinics in the first trimester. Those who had never been pregnant initiated their clinics mostly in the third trimester, and this was significantly associated with initiation of the antenatal clinics. That was found to be at a p-value of less than 0.05. Being previously pregnant was positively correlated with the marital status and level of education. Mothers with lower level of education were more likely to have been previously pregnant. When the variable for parity was adjusted, it was found out that those mothers who had been previously pregnant and also had complications in the previous pregnancies initiated the antenatal clinics area compared to those who never had any complications in previous pregnancies. Complications in previous pregnancy was statistically found to determine the time to initiate antenatal clinic in the current pregnancy. That was at a p-value of less than 0.01. cost implications on initiation of antenatal clinics was also evaluated, and it was found out that 21 mothers who reported the service to be affordable, only 3 had booked their clinic in the first trimester. Majority of the respondents, that is 80.9%, reported that the services were not affordable. Affordability of the services was positively correlated with level of education and employment status. However, it was evident that those mothers who initiated their clinics late in pregnancies had been employed. Therefore, the cost of the services was not a determinant of the time to book for the clinic, and this was insignificant at a p-value of greater than 0.05. In an African setups, men decision is perceived to influence the timing for clinic attendance, but was not the case in this study. Out of 85 pregnant mothers who were advised by their spouses to initiate their antenatal clinic in the second trimester, only 28 mothers initiated their clinics before the third trimester. When a chi-square was computed, the spouse decision on when to initiate the antenatal clinic was not significant. Majority of the respondents were on the right to initiate antenatal clinics, but this did not translate to actual booking for the clinics. Out of 97 mothers who were aware of the right timing, only 36 booked their antenatal clinics at the right time. And there was a negative correlation between awareness and initiation of the antenatal clinics. Let's proceed to discussion. It's evident from the results that majority of the respondents initiated the antenatal clinics in the third trimester. This is in line with studies done by Butcher 2015 and Linda 2015, which was also found pregnant mothers to book for the antenatal clinics late in pregnancy. The results of this study reveal that age, marital status, religion, and employment status were found to rarely influence the time for initiating the antenatal clinics. Level of education was also not significantly associated with timing for antenatal care clinic initiation. These results are in contrast with the findings in Ghana and Malawi, which were conducted, which revealed that increase in age was associated with increased utilization of antenatal care services and early booking. That's according to Yeon and Pell et al. 2016 and 2013 respectively. In this study, increase in age was associated with marital status, whereby increase in age was associated with marriage status but was not statistically significant to influence the time to initiate the clinic. Employment status, which was positively correlated with affordability of the antenatal care, was not significantly influencing early initiation of antenatal clinics. A study that was conducted in Nigeria found that affordability of antenatal services was associated with timing for antenatal clinic. However, in this study, affordability was found not to determine the timing for initiation of antenatal clinic. The results in this study reveal that health status of the mother in the current pregnancy, together with past poor obstetric experience and having been pregnant previously, were the main determinants of antenatal care clinic. The results were consistent with Naweri et al. 2018. However, in this research, ignorance was not a determining factor for antenatal booking, since majority of the pregnant mothers were aware of when to initiate antenatal care but booked the clinics at the right time. In conclusion, the current status of the pregnant mother and past obstetric outcomes are the key determinants of the timing for initiation of antenatal care clinic. However, multiparity was associated with late antenatal booking. Thank you very much for your attention.